I couldn't be able to present on time this day as I had some commitment today. I am recording this now, so I hope it's clear and useful. So I'm going to share my case series. It's about severe imported malaria in an intensive care unit. So let's start. Severe malaria is a medical emergency and often needs management in an intensive care unit. In high parasite burden infection, clinical condition can deteriorate even after initial appropriate treatment due to exacerbation of systemic inflammatory response leading to organ dysfunction. Oman is a country located in the Middle East. So Oman has long been an area of vivax, Plasmodium vivax malaria transmission, but control aiming at eradication was started in 1981. Interruption of malaria transmission was achieved in 2004 and maintained till 2007 when focus of local transmission was detected. However, due to the increase in the number of imported cases, foci of local transmission were detected the following year, which were controlled immediately. Actually, by 2017, we have achieved eradication of local transmission, and all cases after that were imported. So the method of this case series is a retrospective observational study reviewing the medical record of all malaria cases admitted between January 2012 and October 2018 to the Royal Hospital Adult ICU. It is a 700-bed tertiary care referral hospital in Muscat. So all patients fulfilled the WHO 2019 criteria for severe malaria were enrolled. So during our assessment and review, we reviewed all demographical data like age, sex, malaria diagnosis by pig and pin vaccine, clinical assessment, at initial presentation, biopsy, the glaucoma scale, and other scoring system available. And after 24 hours, also reassessment by other score, like SOFA and the batch score. And also, we reviewed all supportive management that patient received, including intubation, vasopressor, renal replacement therapy. Total of 30 patients were included for this time period, and all were imported cases. 9 of them Plasmodium falciparum, 3 Plasmodium and 1 was mixed falciparum and vivax. The 74% were male and 26% were female. 46% Omani and 54% non-Omani, and the median age was 34 years. Comorbidities were presented in 3 patients only, and that was hypertension, chronic obstructive pulmonary disease (COPD), and hyperthyroidism. So we assess the time of presentation. The median period of time from start of symptoms until reaching sought medical help was 7 days, with a range from 2 to 21 days. And symptoms, all patients had experienced fever for a median of 7 days, chills, headache, nausea, vomiting, and 1 patient had 1 episode of seizure. Regarding signs, 1 patient had altered mental status with GCS 4 out of 15, 3 patients have hypertension and 1 ARDS. So this chart is showing complication during admission. So 9 patients developed ARDS, 5 renal impairment, and 8 had impaired consciousness, 7 hyperbilirubinemia, 7 patients had shock, and 5 patients severe anemia, 3 developed metabolic acidosis, and 1 had DIC. 50% of patients, regarding now we're talking about the malaria treatment, 50 patients received ibuprofen plus oral doxycycline, and after 2016, 50 patients received IV artesunate because at this time, IV artesunate was introduced in our institute, and these were followed by AM activity infiltrate for 3 days, and a single dose of ibuprofen was given at discharge. This is for plasmodium falciparum, and for vivax, were treated with chloroquine and primaquine, which were effective for all patients except in one from Pakistan. He failed to clear his parasitemia, deteriorated, so after 3 days of treatment. Hence, he was changed to the activity infiltrate regimen, and parasitemia was cleared. And this graph is showing clinical care management. 5 patients required inotropes, 8 required intubation ventilation, 7 received blood product transfusion, and 5 required renal replacement therapy. Now, regarding the outcome, all patients survived, fortunately. 12 out of 13 had full recovery and were discharged without any persistent complication, apart from 1 patient who developed cerebral edema complicated by obstructive hydrocephalus and ischemic hypoxic encephalopathy. IQR of hospital stay duration was 7 to 18.5. And the median length of stay in the ICU was 8 days. So let's discuss some findings here, some of the important ones. So we're focused on patient delay. So the median time of presentation to the healthcare institute was 7 days. So this is a bit long time for malaria, because as you know, early management and diagnosis improve outcome and prevent severe complications. So delay in seeking medical help may result in multi-organ failure, and even the best intensive care support may prevent a fatal outcome. So this is, we move us to the next important point, which is lack of awareness of travel safety. So here where we need pre-travel advice and travel medicine. So 1 out of 13 of our patients had used malaria chemoprophylaxis. Pre-travel advice with prescription of chemoprophylaxis to high-risk destination and increase awareness to avoid patient delay is very important. Travel health is a specific medical discipline designed to prevent and manage illness associated with international travel. It is usually delivered through primary healthcare with support from specialized unit and Center Public Health Authority. Oman's Ministry of Health is in the process of establishing travel health service at the national level to tackle travel-related illness which threaten the health of the country's population. Another important point here also, doctor delay, which is implementing appropriate strategy for early diagnosis, particularly in primary healthcare system. For anti-malaria treatment, we have already discussed that 50% received ibuprofen plus doxycycline, and after 2016, patients were treated with artesunate, which becoming the treatment of choice for severe malaria in our country after introducing in 2016. And there is substantial evidence in endemic country for superiority of IV artesunate over IV quinine. Two large trials and meta-analysis conducted in Africa and Southeast Asia demonstrating mortality benefit, safety, and rapid action in terms of parasite clearance. Post-artesunate delayed hemolysis was defined by delayed hemolytic episode occurring 7 to 30 days after treatment initiation. It has been reported in 15% treated patients. All our patients who received artesunate were followed with full blood count weekly for 1 month. None developed post-artesunate delayed hemolysis. Regarding the treatment of PFAS, chloroquine resistance was suspected in one case from Pakistan because of persistent symptoms and failure of clearance of parasitemia. So, changed to artesunate thereafter. Chloroquine resistant Vivax was present in most Vivax endemic countries. Then an adjunctive therapy like ICU management remains supportive and improved outcome. Despite numerous studies showed no adjunctive therapy has been shown yet to confirm the survival advantage. Examples of these adjunctive therapy including mechanical ventilation, fluid management, inotropic support, daily assessment of daily assessment of parasitemia, dialysis, and treatment of other infections and co-infection. And all of our patients receive antibiotic because they developed infection or hospital-acquired infection during hospital stay. So in conclusion, severe malaria can be prevented by avoiding patient and doctor's delay. Travel medicine is important to increase awareness among population and to establish good strategies to reduce communicable disease among travelers. Pre-travel advice and use of malaria chemoprophylaxis will prevent infection and early diagnosis, reduce morbidity, length of stay in hospital, and hence resources. Thank you very much.